This is the most important one. I'm trained by Prof. Kosheri for 11 years. The disclosure is Imperial is going to take this work forward in a dedicated way, but I have no other disclosures. So if you look at an example which is gastroesophageal cancer, there is a lot of upper GIT symptoms. So 3% of presentation in primary care with upper GIT symptoms. But if you look at the number of endoscopies done in the UK, for instance, about 800,000, but only 20,000 patients have esophageal or gastric cancer. So too many people have symptoms. We do a lot of endoscopy, but the number of cancer is low. And what this paper showed, that people who refer many patients, they get better survival because they can pick up cancer. So the equation we have is we have high incidence of non-specific disease, but low incidence of cancer. But the diagnosis would be only tissue diagnosis. So the need here is to have a triage test. So not everybody will have endoscopy, but we streamline people to have endoscopy. The example for that, like fecal occult blood for colorectal cancer, like CT scan for lung cancer, so we need a triage test. So the volatile compound are really compound which present in the breath, in the exhale breath, and this is not a novel finding. This is actually has been described in 1971. Linus Pauling, he is a double Nobel Prize winner, and he found 100 compounds in the breath. And we all know that cancer, dogs can smell cancer actually, and many reports for that. So we spent initially about 3 years just trying to know how can we collect breath in a very reliable way. What is the influence of different breath maneuvers? What is the reliability of the instrument? How can really account for confounding factors? So this is the first stage, really, how to do it in a very reliable way. And then we looked at patients normal people, and we did pilot study with patients with cancer to see, do we find compound which is potentially important, which differentiate cancer patient from non-cancer patient. And then followed this by another study, which for biomarker discovery. So the approach we use is not an electronic nose approach. It's not like the dog don't know what the compound, the dog doesn't know what is the compound. What we do is we have identified compound, and those compound, we use them to drive a model. So for instance here, this is, you can use the aldehydes or fatty acids or phenol, and we see the difference from normal to cancer with really, and we combine them together in a diagnostic model. So this is the diagnostic model with an area under of curve of 0.9, and this is a validation set, but this is within the same cohort. So this is an internal validation. So follow this study by another multi-center study, 3 institutions in London, about 325 patients, 1-to-1 model, and we look at how can we look at a different external group, so it's a different time, different people, different everything really. So this is an external validation study. And show the area under of curve 0.85, and with a sensitivity and specificity about 80%. And it's always known that the external validation study is always really less than the initial one. So this means that it is a reasonably, you cannot triage patient who has cancer from people who don't have cancer with a breath test. Breath test is acceptable to patient because completely non-invasive. But the key question really is, I don't think the GP will have too many technologies for each type of cancer. What we usually like to do, can we have one breath test to diagnose multiple cancers? If you go to the to the doctor is take a blood sample and measure, test for blood count, test for liver function, test for kidney function. The question really is, if people go to the general practitioner with symptoms, can one breath differentiate between different type of cancers? So we did another study on colorectal cancer, and we just published, and this is a control group. This is patient with colorectal cancer. This is after resection of the cancer, and this is a cohort of recurrence. So really the model can not only use for a diagnostic, but it can longitudinally follow the patient. And this is pretty reasonable model because there is not much of an overlap in the biomarker. And then the third cancer in the GI tract, which can have non-specific symptoms, is the pancreatic cancer. So did another study on pancreatic, and this is cancer and non-cancer, and we showed a reasonable area under the curve. The key issue here are the biomarker for esophageal and gastric cancer is different from the pancreatic, it's different from the colon cancer. So when patient go with non-specific symptoms, we can have, by collecting a breath, we can look at different models of cancer. So this is, if this goes to clinical practice, this would be the model looks. People who are really alarming symptoms, they can go for endoscopy or a CT scan. If somebody is vomiting blood, they will go to have an endoscopy. There's no question about it. But people who have a non-specific symptoms, we can have you the breath test as the triage test. Then, if it is positive, they can have invasive or more definitive investigation. If not, we can treat them or we can retest them, because with a retest, you get a better sensitivity and specificity. So this is the model which could work in clinical practice if this test prove valuable. The key question really is, do we have a biological explanation of those compounds? Because we can't really think we'll have the trust and confidence of the scientific society and wouldn't be able to improve the model unless we know where are they coming from. So we picked up one of the groups of compound in the aldehydes, and one of the PhD students did his PhD on it. So we looked at the genes which affect cancer, and the aldehydes, gene affect the aldehydes, they come up as the second group. Then we did a qPCR, we showed that ADLH 1 and 3, they are different between cancer and non-cancer, and did immune histochemistry. And this is quite a good plot, because these are the patients who don't have cancer, and this is the cancer group, and you see how the under-expression for people who have cancer. And this is 500 patients, so a reasonable cohort. And then can we really link the compound to really specifically where it's coming from? So this is called the FISH technique. This is fluorescence and site hybridization to get really an objective count. And we showed that it relates to the copy number. But this is slide. These are tissue using LCMS. If you look, you'll find the difference between cancer and non-cancer. This is in tissue. But it correlates the gene expression and copy number with the volatile compound. So the volatile compound, some of them is directly related to the gene concentration and copy number. And we know that the chromosome 17 is co-located with the aldehydes and co-located with the p53. And there's no surprise. So this is patient at Imperial. There's the expression of those genes is different. And this is another 600 patient as an external validation. And this one is quite good because we can use the decanal with the volatile compound because it's related to gene as a prognostic marker of patient response to chemotherapy and survival. So what does this mean? If we can use them as a diagnostics, but we know where they are coming from, and we can use them as a prognostic as well. This key question really, this is work done in the lab, done in London, in hospital in London. But to come to in clinical practice, we need to scale this work up. And to scale it up, there are significant challenges. One, then, each lab and each collection should be the same. We need to have a method to transport, because initially we used methods which would be for 48 hours. Now we need methods which travel between cities. We need to have a high reliable instrument. We need to have really, if we go to clinical practice, we need to really, the identity of the compound, we need to do them very quickly, so very accurately, so we need to have a multiple platform validation. And we need to have an automated system, because we need to do a few hundred patients in a day. And the other thing is the quality control system. So this is what we are currently using. These are steel tubes, and there is fiber in it, and this can store the compound up to 4 weeks. So this is pretty robust to transport and robust to keep for about 4 weeks. And then we did some work using multiple platforms, and this is our model. We collected, we identified, we're using PTRMS and GCMS to identify it. So this is the workflow. We collected. We have a better system will be coming up next year. We're working on it. Collect it in a tube and do it with 2 machines. And this will drive the model. So the next step to do is to do a study in upper GI, 7,000 patients, but in total for GI tract in 35,000. And this is a decent number, which will allow us to make sure that the reliability of the test is valid. And the other thing is we are working on different methods to improve the sensitivity of picking and the machine and the differentiation. So I think we expect the 80% sensitivity will be between 85 to 90% over the next 2 years. And this work with a lot of people working on it, as you would know. Those are 7 PhD students and 4 scientists that have been working on this work. Thank you.